All right. Well, without further ado, I am going to go ahead and introduce our webinar. So this is our second webinar in this series. It's called The Overlap of Personal and Professional Trauma in Veterinary Medicine. My name is Darlene Boss. I'm the Executive Director of NAMVI, or Not One More Vet, and I'm really excited that we were able to, along with our partners, present this series of webinars, and I hope that they will be extremely helpful for everyone or anyone who needs them in the veterinary field. I want to introduce our speaker today. She's actually a board member for NAMVI, as well as being the serving on our student support and mentorship committee and being an active speaker in support of NAMVI's education initiative. Dr. Taylor Miller is a 2010 graduate of the Oregon State College of Veterinary Medicine and a professional counselor associate in the state of Oregon. Her interest in mental health began during vet school and culminated in the pursuit of a master's in mental health counseling. After 9 years exclusively in the veterinary world, she has restructured her time to focus on her mission of improving the mental health and well-being of veterinary professionals as both a counselor and an educator. So I'm very excited to introduce to you Dr. Taylor Miller, our presenting speaker tonight.
Okay, well, hello everybody, and thank you so much for joining me here today on this second of our series of 3 trauma-related webinars. And my name is Taylor Miller. I'm sure that you've gotten way more information about me from Darlene than is absolutely necessary, but here we go. So the outline that we're going to be working with today is more experiential than it is clinical. So we had a wonderful introduction and very thorough dive into the aspects of trauma that are covered in mental health by Dr. Dustin Kirschnick. And we also have, following me, a wonderful discussion of how to implement some strategies in your team in the hospital to take care of yourself and to counter trauma. So my section is about how we experience trauma as veterinarians in this world. So how do we think about trauma? What did we bring with us into the field of veterinary medicine? How do we handle trauma as it occurs? How we are trained to approach trauma, and how we synthesize that information as we experience trauma within our career. And then, if we think about what's happening in the field of veterinary medicine, what are we taking home with us, or how is that experience in the field impacting our ability to live outside the field? The trauma that we don't expect. This is a category that, particularly given how we are trained to handle trauma, can take us by surprise and throw us off. And so we'll discuss a little bit what that can look like. And then what does our trajectory look like from this masking, which we'll explain in a minute, to coping, to actually healing from trauma. And I want us to keep several things in mind. Whenever we enter into spaces where we are discussing trauma, it's important to realize that trauma can be very triggering. It can be very difficult for people to discuss. And it's important to recognize that I only have my perspective, and that perspective is informed by my status as a cisgender, heterosexual, white female practicing small animal medicine. And that limits some of what I'm able to understand or perceive, perhaps. As much as I try to expand my perception, it is limited, and please take that into consideration. I also want to emphasize that this presentation is based on my experiences and conceptualizations of trauma, as well as the many conversations I've had with veterinary professionals around mental health. Further, while it is informed by my counseling education, I am not using a strictly academic lens. So I will be using terms that I have created. I will be talking about trauma in a more generalized way, perhaps not always sticking to the technical definition of trauma. So this is a little more loosey-goosey than perhaps I'm used to, but I want us to have a conversation about what it feels like to be in veterinary medicine and experience trauma. Again, any stories or perspectives that I share are mine and are not meant to encompass the whole of the veterinary experience, and they are not meant to be the right stories or the right perspectives. So again, moving things around. Being mindful as you engage in this conversation if you notice yourself becoming activated, feel free to step back, feel free to turn this off, feel free to re-engage. Also, when we start sharing question answer time, please be respectful of anyone else's perspective, even if it clashes with yours or doesn't align well with the way that you experience trauma. And finally, the images that I have chosen for this PowerPoint are meant to add an element of softness, and they are not meant to minimize the topic. Here we go. How do we think about trauma? This is our professional perspective. So when we first hear the word trauma, most often we think, is it blunt force? Is it penetrating? Is it a fracture, a contusion, a toxic insult, a burn, erosion, concussion? All of these words that we learn to give us a picture of what is going to be arriving in our exam room, what's going to be arriving on our table in the stall, what animal problem is presenting. So that's the first thing that we often think about with trauma. And while the elements of each individual trauma can be severe or distressing, most often, once we have gotten into our training and once we have moved into that professional perspective, the elements of a trauma don't tend to shock us so much as the circumstances of the trauma. Think about it. If there is open flesh and it is bleeding, that by itself is maybe not scary or traumatizing per se, compared to knowing that perhaps this open wound occurred because someone with a machete hit the dog. That makes it traumatic, right? So this is starting to give us an idea that it's our perception that begins to define an event for us or a circumstance for us. And again, this is our professional lens that we're thinking about right now. So circumstances, we have the presentation, and that's not necessarily neutral, but fairly neutral. It is a break. That can go on to a chart. It's a very neutral fact. And then we start adding layers of perception, perspective, and emotion, the circumstances of this trauma. Was it an accident? And if it was an accident, was it an avoidable accident? It can feel very different to have a dog that chewed through its collar get hit by a car. That is tragic and it is sad and it is awful, versus a new puppy on an extendable leash that ran out into the highway because its retractable leash thing didn't work. That feels more difficult because it could have been avoided. We hate those leashes. Why do people use those leashes? We can imagine so many ways in which this puppy would not be on our table traumatized. Was it neglect? Was it abuse? Those can often hit us much closer to the heart and feel more traumatic than the same perhaps injuries that resulted from an accident. So circumstances make a big difference in how we perceive trauma and how we align with a circumstance. Our involvement can also be important. Are you the one responsible for the repair, or are you a participating party? This is not meant to minimize anyone who is not the primary control on an animal. Sometimes it can actually be worse. If you are not the responsible one, if you're not the one who's in charge and you feel more powerless, perhaps, that can make something more traumatic. Conversely, if you are in charge and the outcome is dependent on your choices, that can make it feel more traumatic. So how you're involved can, again, shift your perspective about whether something is experienced as traumatic or not. We can also have that involvement impacted by whether we view ourselves as having sufficient resources, whether that's training or whether that is actual resources. Do I have the money or the input available to offer this animal the best care? Do I have the supplies on hand to provide the best care? Do I have the staffing that I need right now to provide the best care? So something that might be intense isn't viewed as traumatic if you have all the resources you need to manage the case. It might be viewed as traumatic if you're watching suffering or you're watching a deterioration of your case and you feel unable to provide the care that you know is possible. And then whether you have a sense of purpose or whether you feel supported in your role as you are engaging with this trauma. Sense of purpose might be whether or not you feel like your intervention is going to make a difference long term. Certainly in cases of abuse or neglect, there can be a sense that I'm repairing in order to return this pet to a situation that's going to continue to be awful. And absolutely, there are steps that we can take to try to minimize the chances that that situation will occur. But it can change how we experience something if we feel that our efforts are, if not futile, at least not going to yield an outcome that we want, and whether we're supported in this role. Outcome can also play a part, right? Something can feel awful, and yet if we're able to achieve an outcome that is wonderful, the perspective that we have when we look back on that scenario, on that situation, can have an overall positive cast. And it can also depend on how our clients perceive the outcome, right? Because we can see that this outcome was fantastic. I worked with this amazing veterinarian, and I'm sure some other large animal individuals here will have a similar story where there was this horse who, did the thing, it jumped over the thing and it slit its belly all ways to Sunday. So huge gaping wounds and just awful. And this veterinarian that I was working with pulled out miracles, and he got everything healed up beautiful. It was amazing. I did not think that this horse was going to have as nice an outcome. However, this was a paint, and you will probably already know where this story is going, right? And he sewed back the white patch just a smidge off. It wasn't perfect anymore. It was just a smidge off. And we ended up with a disgruntled client. And so what felt like a victory became this recurring input from a client who shared with other clients, of course, that things got screwed up during the veterinarian's efforts. And it became this really complicated, difficult memory for this veterinarian because of the client's perspective overshadowing the veterinarian's perspective of a very successful outcome, which was survival in this case, and it was not guaranteed at the beginning. Then we can have complicated outcomes where, yes, the dog is healthy and happy, but it only has 3 legs. Depending on how we engage with that scenario, it can either feel like a positive outcome or it can feel like a loss. Maybe we focus on the fact that we weren't able to save the leg, and that feels like a negative, and it casts the whole scenario into a negative light. So our perspective, again, this is the theme that we're looking at, and this is something that Dr. Kirschnick focused on quite a bit, is the stories that we tell ourselves about a circumstance or an event can strongly influence how we are able to repair ourselves following that event if it's perceived as traumatic. And then, of course, we have those poor outcome situations. So a poor outcome, especially if it's combined with a difficult presentation, difficult circumstances, and perhaps some factors that make your sense of involvement or sense of purpose difficult, that just exacerbates everything. A poor outcome, even if you have everything else positive, might be more balanced. It might end up being an overall neutral. We did the best we could. You're able to reassure yourself of that, and you're able to be strongly reinforced in that belief, but you still have the poor outcome. So this is our professional brain, right? Working with the more common thing that we think of when we hear trauma. We think of the medical side, but that's not the only thing that we have to deal with, right? So the personal perspective, and we're going to get back to this big T, little t trauma. But when we're thinking trauma, when most people hear the word trauma, their brains go to a lot of things that impact humans. And so here are some of the broad categories. And again, these are things that I generated. I made them up. I may have missed something critical. You can let me know. But here we go. So some of the broad categories are tragedy, loss, and death. This is probably the one that we most frequently think of. This is a car accident. This is the stillbirth of a child. This is the loss by suicide of a friend or colleague. This is losing someone's possessions to a house fire, a missing person, a natural disaster. These are all events that frequently result in an individual with trauma. And they can all be things that you have experienced, you've not experienced, you've avoided, you know someone who's experienced these. So these, in the grand scheme of things, happen to people we know, they happen to us. They happen. Injury, medical issues, or loss, these can be things like medical error, not one that you do as a professional, but a medical error that you experience as a patient. If you lose lose a limb or an amputation, this is a trauma. Emergency cesarean, we often forget that things that are normal, things that occur frequently, can still be traumatic to the person who is experiencing them. So even though we know that it's relatively commonplace for a birth to proceed in a way that results in an emergency cesarean, if you are the person in that moment experiencing the emergency cesarean, it can be very traumatic. And this is one of those things that we can get our brains tied up in knots about. This is one of those things that sometimes we label as a little t trauma. So big T is one that everyone agrees on. Yes, that was traumatic. Little t traumas are ones that either as a society or as an individual, we tend to discount. And if your trauma has been discounted by others or minimized by others or is not validated by others, you can have a redoubling effect. You have the trauma itself, and then you have all the feelings of blame and shame of, why is this affecting me so much? Why can't I get over this? Why am I having trouble managing the feelings that are related to this event? So things like an amputation, almost anybody would agree that if you were a person who has experienced an amputation, that you have suffered through a traumatic event. If you have had an emergency cesarean, there are many people will say, well, yeah, but your baby's fine, right? You're fine, right? And if the outcome is good, apparently it's not supposed to matter that the process was traumatic. So we have to, one, check ourselves and make sure that we are not contributing to that kind of dialogue, but also recognize that if we are experiencing something as traumatic, it doesn't matter what anyone else says. That is something that was traumatic for us. And we are allowed to have those feelings. We are allowed to feel valid in those feelings. We are allowed to work through it in a way that is trauma-centered. Loss of sight, disfigurement, all of these things can be very traumatic. Violence, assault, or anything that impacts our ability to feel safe can be huge traumas. Physical assault, sexual assault. If you experience combat, natural or mass-made disasters, we have natural disasters in two places. And sometimes that's based on the abruptness of what has happened. For instance, a slow creeping flood that maybe gets your basement wet, it could be classified as a natural disaster if the flood area is not where you usually are. Or we could have a huge wave that comes and sweeps out the first story of your house. So the element of trauma and the way that we perceive it can be either categorized as more of that's sad and tragic versus this is more of a violent assault upon myself or my property. Attack on personhood. This one sometimes gets left behind. And this is important because it's not an isolated event that you can point to necessarily. There might be micro events within that circumstance, but it can be more insidious. And so sometimes we are reluctant to label it as trauma because it's not a thing that you can point at. And this can include elements like discrimination or prejudice, gaslighting, bullying, emotional abuse or neglect. These are all things that, by the definition that Dr. Kirschnick provided us, is emotionally harmful and has potential for lasting adverse effects. So leave room for your framing to include things that maybe feel more insidious, but do attack who we are and who we feel we are and whether or not we feel okay or safe in the world. And then the one that we were perhaps most familiar with, or the one that people talk about most often when we are discussing trauma in veterinary medicine, is this idea of vicarious trauma or secondary trauma or being a witness to trauma. And we are certainly a witness to trauma frequently. Vicarious or secondary trauma often give us the perspective that it's somebody else's, another person's trauma that we are adjacent to. So this could be that of a loved one. This could be the client's trauma and experiencing their emotions. So this category of trauma is very common for medical individuals and first responders. loved ones trauma, or social trauma. There are some interesting studies and interesting perspectives that talk about how media these days can contribute to a version or a different flavor of trauma. Coverage of the pandemic, absolutely. Many people felt traumatized by the numbers, the death reports, the images, and we're going to have more information, I suspect, in the next 15 years about how that kind of coverage, media coverage, impacts individuals. So what do we bring with us into the field of veterinary medicine that influences how we perceive trauma and how we react to trauma? So all of us have a worldview, something that we built up during our childhood and contributed to as we became adults. And this can include things like spiritual beliefs and sense of agency. There's obviously a much larger category of things that impact our worldview, but these two specifically can greatly impact how we engage with the trauma we encounter in our veterinary field. Spiritual beliefs can inform our sense of purpose, as well as whether we believe we are instruments of a higher power or whether we are acting individually, how much responsibility you have for what occurs, what happens after death. All of these things can play into how you feel about trauma. And it can also play into your sense of agency. And this is our sense of what we are able to control. Oftentimes, trauma is accompanied by a sense of loss of that control, a feeling that we are unsafe or unable to manifest the next step in our path. And that sense of disorientation or that sense of being lost can be a big part of what is so difficult to carry about trauma. So that sense of agency is something that we have a sense about when we come into the field, and it will of course develop as we keep going. Values. Some of these values you develop more strongly within the veterinary field. Sometimes you have them before and you come to the field with them. But things like stoicism, if that is a value that you have, it's going to change how you engage with trauma and healing. Compassion, perseverance, certainly in order to pursue any path in veterinary medicine, there's going to be an element of perseverance because it's not an easy field to be in. And so that value, again, might trend you in a direction that discounts your own trauma or that discounts your need for attention and help and healing, because I'm able to go on, so maybe I should go on, which gets us to the next one, shoulds. And this is all about expectation. What should trauma look like? This can decide whether or not you feel like you have experienced trauma or whether your trauma is valid. Again, lots of bunny ears today. Should I be able to get over this? I should be able to handle this. I should be able to take this on for someone else. All those shoulds. I want you to hear my voice in your head when that word pops up, I should. And I want you to think about not shoulding all over yourself. You should never should all over yourself. So hear my voice in your head. And if there's the word should in a sentence, you should question that sentence. I just use the word should. This is the one time when it's valid. But questioning that sentence will give you an idea of why you feel that the statement following should is important. Is it important to someone else? Is it a socially prescribed should? Engage with that thought and see where it takes you. And we also come into the field with some pre-programmed coping strategies. How do we manage things that are painful? And how do we think about trauma? What kind of scripts are in our head? What stories do we tell ourselves about traumatic events? And then we have this internal trauma scale, and all of us have this, whether it's conscious or unconscious. We categorize things as, oh, that's unfortunate. Oh, that's really sad. That is tragic. And then we have our little t traumas. Yeah, that was traumatic. And then we have our big T traumas, trauma. capital T, emphasis, bold, exclamation point. And where we put things on the scale is very personal, and it's influenced by what we see, what we engage with, the trauma that we've experienced, and the trauma that we witness. And we may start out in a world where something that counts as a little t trauma over time gets downgraded into simply sad or unfortunate. The very first hit by car puppy that you see might feel like it's a big T trauma, might feel like it's little t trauma. And maybe if you live in a place with a bunch of busy streets, 5 years from now, it's sad or it's tragic, but it's no longer traumatic. And of course, this all depends on those circumstances, those other factors that we were describing. But it's important to recognize that we each have different scales, we each have different categories, and we put things differently from other people. And just because someone else doesn't categorize something the way we do, that does not mean that it's wrong or that their experience is invalid. If that is where you categorize it, that is how you experience it, and it is the way that you experience it that is important. So part of this presentation today is about recognizing how our own perceptions of trauma influence how we experience our own and how we perceive other people's trauma. And it can be really important not to impose your own scales and your own thoughts onto someone else, because each person's experience is so unique and individual that we can't be in their shoes until we've lived through their whole childhood. A person's childhood trauma is going to influence where the scale gets set. It's going to influence patterns of response and coping strategies. It's going to influence expectations. And all of those things happen before you ever step foot in a veterinary hospital. Training and entry into the field. What was your training program like? Whether this was a formal education situation like a vet school or a vet tech school, or whether this was walking in one day to a clinic and being trained by the staff there to fill a role. And then your personal and professional interface. How do people around you acknowledge or witness your trauma with you, or do they ignore it? And how do you bring your trauma home? How do people at home help you with that trauma? So how do we manage that interface? So all of these things were important in how trauma ultimately shows up in our body, in our brain, in our emotions, the way that Dr. Kirschnick was describing. So how we handle trauma. And this is where that training piece comes in, right? Because the medical approach, a trauma arrives, you need to be calm, you need to be clinical, methodical, detached, and focused. In a medical trauma, we often have clearly understood priorities and roles. We need to breathe, we need to beat, then we need to stop bleeding. And we have this checklist in our head that allows us to approach a trauma in a methodical way. Maybe it's not controlled. Oftentimes trauma, there is running, there is dashing about. However, we know instinctively what those priorities are, and we can work through them in order. And the pieces of us that allow us to approach a case that way make us very effective clinicians, right? If we are able to be calm and clinical and methodical and detached, then we are able to focus on the problem, and we have the best chance of effective functioning, which means that we have the best chance of affecting a good outcome, which is amazing. That's what we're trained to do. The longer we work in the field, the better we get at it. It's great. It has its place. And this is where we can get into trouble, which we'll talk about in a little bit. But what are we doing when we have this medical approach? We are deferring our emotions in favor of effective functioning. And I think that's important, particularly because from the outside, an effective clinician may look like they don't care. They may look like it doesn't matter. They may look like it doesn't impact them. And it can create some misunderstanding. So I had one emergency clinician that I worked with briefly, and they had a brand new technician that they were training. And this technician had not had a lot of clinical experience, but was really interested in emergency medicine and the science of it and the immediacy of it, in the results and effect in that category. And as most of us are, this person also had a very genuine, deep love of animals. And those first weeks, as this clinician and I were discussing, were really trying because their emotions would be engaged during some of these awful traumas that they experienced and witnessed and were part of. And their perception was that the senior clinician didn't care or wasn't involved. And it sets up a dynamic that makes one person's feelings more than, one person's feelings less than, or it invalidates feelings. And it's because there's this perception that because a person is able to detach, that they don't experience or they aren't aware of the emotional content. And that can be misleading and difficult, particularly for people outside the field. But inside an individual, we also have to recognize that deferring emotions or deferred emotions, they still exist in there. And if we don't give them time or attention, they can get twisted and stuck and lost even. And they become this background buzz that is uncomfortable and impacts us, but perhaps we haven't acknowledged. So just because we are able to defer emotions doesn't mean that we shouldn't take time at some point to examine them more thoroughly and allow them their process. We can also see the contra side to this, that if you, in any given moment, for whatever reason, you don't feel you're able to be methodical, clinical, detached, or focused, that instantly becomes a weakness or a failure. If you do feel like your emotions have overcome you in a situation, you're not able to be the clinician, that's now a failure or a weakness rather than a fairly normal human state and something that should be addressed with compassion. So this is kind of a double-edged sword. It allows us to do our job in a way that is effective, but sometimes it can bite us, either by stuffing everything down or by leading to stories about our failure or weakness, given that moment where we can't, where we are unable to engage, especially with your own pets, as we know this is one area that is acknowledged as an understandable reason that you can't be calm and collected. But there are other times too, and that's okay. And then many of us are also caretakers. So the caretaker approach says that in a scenario where trauma is occurring or a traumatic scenario, as a caretaker, I need to be the safe person. I need to be safe and stable. I need to be peaceful. I need to be able to offer compassion and reassure whoever else is in the room that needs help recovering or being stabilized in this traumatic scenario. And it's the typical thing where you're putting the needs of others before your own. And this also has its downsides and its problems, despite being something that our clients appreciate in a room. In a scenario that is sad or tragic, if we are able to be that calm, stable, reassuring presence, that offers a lot to our clients and helps our patients, but it has its costs. And some of those costs are, again, that we do not have an opportunity to offer our genuine emotions because we are creating this safety for someone else. Sometimes we intentionally turn the focus on someone else in order to escape our own emotional response. And sometimes, if we feel like this role is being forced on us, there can be resentment that I don't have a chance, that I don't have a turn to mourn or to do whatever it is that this grief or this trauma is telling me that I should be able to do. So, personal example, I lost my father this last year, and I was the one who had to inform my mother. Not a great scenario. And I noticed it was obviously an extremely emotional moment, but I noticed myself turning on and off and on and off this caretaker mode, and it was very disorienting. My mother began to cry, and I went into caretaker and became stable and quiet and peaceful. She started offering sympathy. I started crying. She started crying again. I went into stable, compassionate, peaceful, dry-eyed. So I watched myself like flip back and forth, and it was very distressing. Just as an experience outside of the instigating factor that was causing this experience. And then you have to tell the children. And so I am now not the daughter experiencing the loss of a father. I am the mother needing to be a safe, stable, peaceful place for my young children to process their loss. And there are obviously points where this is important. I mean, a 7-year-old's emotional well-being, I think, comes before my emotional well-being. However, if that pattern continues and every day it's all about making sure things are safe and stable for them, and this is personal experience, but you notice several months out that I haven't given myself an opportunity to grieve. I haven't given myself an opportunity to experience what was a fairly traumatic event. My father died overseas unexpectedly in an accident, and I got a call from the consulate in that country. So it was a very unusual scenario. But that caretaker approach can twist something that is already difficult and traumatic and redouble it and change it into something that now has two sources of trauma. My response is traumatic and the event itself was traumatic. So noticing when those modes are triggered in scenarios where they may not be necessary or where they may not be appropriate, or even if it's an appropriate scenario, if that caretaker mode extends beyond a time frame where it is appropriate. So taking care of ourselves needs to be part of how we process trauma, or that trauma remains unprocessed and we have to carry it with us, another rock in our backpack. So what we take home with us. So this is thinking about all of these things we've been talking about. How does that give us our current state? How do we end up experiencing trauma because of these scenarios that we've talked about? So the medical approach we've already looked at. Would we work on that practical over an emotional response to trauma? We end up with a backlog of emotional processing. And sometimes we'll apply this medical approach to scenarios that are not medical. So we have this experience of using that clinical approach to work through the practicalities, shall we say, of a traumatic experience. And we can turn this on in non-medical trauma experiences. And while that may allow us to get practical things taken care of, it may allow us to get our loved ones to a hospital after a car accident, it may allow us to process the financial aspects of taking care of someone who's died. It may allow us to do all of these practical things. But again, if we prioritize practical over emotional, we're going to leave a lot of emotional processing unmanaged. The medical approach can redouble that idea that we value stoicism, perseverance, the shoulds, and it can make us more rigid in our compassion for ourselves. We don't give ourselves we even think about it sometimes as the luxury of grieving, of processing, of managing our emotional health, because I should keep working. I should put food on the table. I need to persevere. And because you're able to, sometimes we assume that if you're able to, that you should do it. But that's not always the case. And it's certainly not healthy long-term. And sometimes we get into trouble because we begin to impose our shoulds on other people. I can keep working. You should be able to keep working too. I am able to keep functioning, so you should be able to function too. And this can be a real problem, especially with loved ones or colleagues, when you have experienced a trauma or a tragedy together. If you aren't able to allow somebody else to process their trauma their way. And then the caretaker approach. We have that reluctance to burden others. So again, even if it's not a medical scenario, we begin to notice that if there is something that we experience as traumatic, if I can handle it, if I'm able to handle it, if I can persevere by myself, then it's not worth burdening others with my problems. And certainly that's not helpful. And oftentimes our loved ones wouldn't want us to keep things to ourselves, but we have this sense of being self-contained, and taking care of other people becomes more important. And then of course, the corollary is that if we do this and we maintain this rigid functioning outer shell, sometimes we feel resentful or hurt when a loved one can't tell that it's hard for us to do that, or they don't look past the mask to see how much we're hurting. And it's difficult because we shouldn't rely on someone else looking past our mask to offer us compassion. We should be able to ask for it. But it's also a trap that many of us fall into because we are able to keep going. We are able to persevere, but we also want to be seen as someone who is hurting or has been impacted. So again, here are these elements that change over time, right? And that can be reinforced or deconstructed over time as well. The trauma that we don't expect. So we have this approach to trauma, this clinical approach to trauma. We have our caretaker mode. We have everything that we have brought from childhood in terms of values and priorities and the way that we approach trauma. And so on any given day, many of us feel like we are competent and capable of dealing with most things that come at us. It's when we have something that surprises us that we often feel like our preparation or our tools get mislaid and we aren't able to cope in the way that we expect. And sometimes simply the fact that we aren't able to cope in the way that we expect to cope, that becomes part of the trauma. So if you are somebody who has experienced tragedy and loss and death, and you feel like you have built up a repertoire of really good coping mechanisms and really good coping skills, it might come as a surprise to you that you are unable to watch a dear friend go through a loss because you yourself have so many tools. You've figured it out. You've got it figured out for you. But this idea that my friend is suffering, that somehow you don't have the tools for, or is unexpected, your response to it is unexpected. And it can be really difficult to feel disoriented when you're trying to manage trauma. Or conversely, you may be somebody who has maybe you work in an area where there are a lot of abandoned or neglected animals, shelters for sure. You might see a lot of really desperately ill or injured animals. And you have found a way to engage with that trauma that allows you to be functional and safe and keep going. But maybe you have an injury yourself, and suddenly all those things that you thought you had a handle on, all those ways of coping and managing aren't working anymore. So if you're feeling out of your depth, sometimes it's good just to notice that the reason I'm having trouble is that this is new. And if we think about any other type of learning that we do, a new or novel circumstance is a place where we have to learn. Even if we learn to apply old tools in a new way, we still have to learn something new. There are new patterns, there's new normals, there's new coping mechanisms, there are new strategies. So reminding yourself, if you are feeling overwhelmed with any particular angle or type of trauma, that this is something that I have the tools to learn how to deal with. Maybe I don't have all the things yet, but I know how and I can learn. And it's okay to not be okay for a while as well. It's okay to let other people help you. And that by itself can be a really difficult thing for someone who is used to being the competent one, who's used to being the capable one, that it's okay to not be okay. Sometimes it's the same type of trauma, but novel circumstances that make it difficult, or a novel involvement. In the hospital, when you have your staff and when you have your supplies, when you have your orientation as a veterinary professional, you may feel competent and capable to address anything that comes through the doors. But if you are walking down the street in your beach clothes and you witness an accident, that may feel very different because your involvement or your role or your ability to engage is different. And so you may be struck by something in a very new or novel way. So the main part of this slide is just to give yourself grace and to offer yourself compassion for times when you don't feel like you can be that clinician, when you don't feel like you can achieve that distance that you need in order to cope in the moment. And then we want to look at how we move from masking to coping to healing. And I'm generally not a fan of the word baggage. Someone has their baggage, but I like this picture too much, so I left it as baggage instead of backpack. But one of the metaphors or the things that I like to think about is all the things that you've dealt with that are painful are rocks in your backpack. And maybe you've got good straps, you've got a nice chest band, and you're able to, it's comfortable. The backpack itself is comfortable, but it's still heavy. And it means that everything that you do, you're carrying this load with you. And maybe step by step, it doesn't matter because you're strong enough to carry this backpack. But how many more miles could you go in a day, in a week, in a lifetime if your backpack was a little bit lighter? How much more pleasurable would that walk be? And what would it be like, perhaps, to take some of the rocks out rather than just adding them in? And so, because I love to belabor metaphors, these are lists, or this is a list of things to consider that might help you orient yourself around how you experience trauma, how you carry trauma, and how you engage with trauma in your own life. And these are very broad and general. Obviously, if you have something specific, working with a professional is ideal. You're also going to hear from Angie Aurora, who's going to give you some wonderful tools about working as a team to help minimize trauma and deal with trauma. Take rocks out of your backpacks together. But think about, what rocks are you carrying? What childhood traumas are in your backpack? What traumas do you add on a daily, weekly, yearly basis? Which are the big rocks? Which are just little rocks that add up? How long have you been carrying each of these rocks? Do you ever take them out? How do you think about them? Are they burdensome? Are they painful? Or is this backpack just part of you and it's part of who you are and how you move forward? And what do you think about these rocks can be determined, of course, by the presentation, circumstances, involvement, and outcome of each one. Are they sharp or smoothing down? Sometimes you go to put your hand in your backpack to take something out and all the rocks are sharp and it cuts up your hand. It's too painful to look at. It's too painful to approach. Or with time, are they smoothing down, becoming less sharp, still something to carry, but less impactful perhaps? And how does carrying your backpack change the way you engage with the world, with your loved ones? Maybe you're okay. Maybe it's not too heavy. Maybe you're fine. But while you have it on, it's harder to stop and play in the stream with your kids, or it's harder to stand and just enjoy the view for a while with another loved one. I realize this metaphor is getting a little heavy and sticky, but thinking about what our trauma takes from us, how it shades things, and how much of that is how we think about our trauma. And then, are there any shoulds that prevent you from lightening your load? This can be particularly important in your professional role. I should have caught that sooner. I should have been able to save that pet. I should be able to get over this. Those shoulds mean that we keep holding on to those rocks that aren't ours. They're not our rocks, but we've taken them anyway and we put them in our backpack because I should have been better. I should have been more. I should have been different so that the outcome could have been different. And Dr. Kirshnick has a wonderful series of questions that you can ask yourself to help reorient your thinking around some of those types of questions or some of those types of thoughts, to help reframe and maybe let you release that rock, that particular rock. And thinking about how those medical or caretaker personas or childhood patterns may influence current thinking, despite the fact that they might be outdated, or don't apply to a particular scenario that we're thinking about. And this brings us to the end. These are a lot of some of my favorite resources. Obviously, NAMVI is prominent here because it's a place that I feel is doing incredible work to try to bring mental health awareness and tools to all of our veterinary professionals. Lifeboat is a wonderful place for individualized support. NAMVI's list is growing currently, and it's offering a place for us to find resources, local resources that are veterinary professional friendly. We have our our different areas of peer-to-peer support. NOMV students have moved to Circle. They're off Facebook now. So here is a QR code for the student circle. And we have our NOMV support staff and our primary NOMV page. Brene Brown is amazing with regard to shame. And shame is one of those things that keeps trauma hanging on. It's one of the shoulds. Headspace is great for mindfulness, which is one of our key tools in being able to engage with our thoughts in a new and different way. And then Veterinary Mental Health is a podcast that I have sorely neglected, but I will hope to contribute to as the year moves along. And I talk about all things veterinary mental health and am always looking for topics or questions. But given the little time we have left, I would love to answer some questions or let someone else share their story if they have a desire to do so.
And Taylor, we do have a couple questions right now. So the first one is from Shay. Shay asks, could you briefly explain what Student Circle is?
Absolutely. It's a platform. So it's apparently the kids these days don't get on Facebook anymore. So it's a new platform that allows students to engage without some of the distractions of ads or algorithms to displace topics or conversation threads. So we're hoping that it will be a place where we'll see more students engage with mental health topics and peer-to-peer support.
Thank you. I also wanted to mention, we had someone ask a question about sort of workplace issues. And so I wanted to mention that NOMV also has a new program, brand new program called Clear Blueprint. Taylor's laughing at me because she knows I love to talk about Clear Blueprint. But that's exactly what it's for, is for workplace wellness. And that's on our website as well. So Taylor, next question is, oops. Sorry. It was my apologies. I'm having technical issues. Can you tell us a little bit? I don't have another question up here, so I'm going to ask one. Can you tell us a little bit about how having been a veterinarian informs the way in which you counsel people?
Oh, I love that question, and I could talk for way too long on it. So please stop me if I get going too far. But I definitely grew up in a world in which counseling or mental health help was for weak people and for people who couldn't hack it or be stoic enough or figure it out themselves. And I eventually ran up against a large enough wall that I thought, well, I guess I am weak. And so I went and got help and thought, oh my goodness, this is absolutely amazing. And that informed my desire to enter the world myself. And one of the things that I think can help people, particularly who have a clinical background, is to demystify things like anxiety and break it down in terms of what's happening in your brain. This is not a moral failing. This is an interaction between your prefrontal cortex and your amygdala. And we know all these structures and we know how this works. And so having an explanation for what is happening in your brain that is voluntary, that is involuntary, can give us a sense of compassion for ourselves for those things that are involuntary and help us zero in on those voluntary items and give us tools that can feel practical. Don't get me wrong, I love the ooey gooey squishy bit, the woo-woo stuff. I'm all about it now. But I'm also able to help some of the mental health pieces feel practical and feel approachable from the clinical framework that we already have installed. So we might as well use that framework to make advances or steps forward in the mental health.
Awesome, thank you. We got another question. Could you tell us more about how Lifeboat works?
I will be happy to dive in, and Darlene will jump on me if I get anything wrong. But Lifeboat is an asynchronous platform that allows you as an anonymous user to to engage with a pod of people, so not just one person, but a group of peers who are themselves supported by a mental health professional. So you are able to discuss whatever it is that is difficult in your life, whatever it is that's causing pain, with a group of peers who are highly trained, who can help you work through that stage. They can offer resources. They can help you reframe what is happening to give you clarity on what your next step might be. And they can offer coping skills or mechanisms to get you through to the next day, to the next day, to the next day, until you have a more stable system or support group in place. Did I catch everything there, Darlene?
That was perfect. Yeah.
Okay. Oh, good.
So we don't have any more questions and we're just about out of time. So before we leave, I wanted to mention that we do have one more webinar in this series. So that is Trauma-Informed Care in Veterinary Medicine by Angie Aurora. And so we're very excited about that. It's going to be June 21st at 5 p.m. So make sure that you register for that and tune into that amazing conversation. Thank you so much, Dr. Taylor Miller, and everyone who joined us tonight.
My pleasure. Take care, everyone.